On behalf of the American Heart Association, I'd like to welcome you to today's webinar, Shared Decision Making Around the Benefits and Risks of Anticoagulant Therapy. My name is Liz Olson, and I'm a Senior Quality Programs Manager for the American Heart Association. Today's webinar is possible with support from BMS Pfizer Alliance. I'd like to begin today by going over a few items so you know how to participate in today's event. If you'd like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you'll receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenter at any time in the questions pane of the control panel. We'll collect your questions and address them during the Q&A session at the end of today's presentation. It's my pleasure to now introduce our speaker for today. Ricky Fenton is a PAC from Greensboro, North Carolina. He received a Bachelor of Science degree in Exercise Science from Brigham Young University prior to pursuing physician assistant studies at South University in Savannah, Georgia. He worked as a cardiology PA at St. Joseph Hospital in Savannah before moving back to his hometown of Greensboro to work at Cone Health in the atrial fibrillation clinic. He has a passion for patient and provider education and loves spending time with his wife and 2 daughters. Ricky, I turn it over to you. The floor is yours.
All right, thank you for having me. I'm happy to be here to talk today about one of the 4 F's of anticoagulation assessment, and that's the fear of bleeding. And so we'll go ahead and hop right in. I don't have any financial interest to disclose. And so today we're going to talk about and discuss the shared decision-making process for anticoagulation as it relates to bleeding risk. And so as part of that, we'll talk about barriers to anticoagulation for both providers and patients. We'll talk about some of the assessment tools available to assess stroke and bleeding risk, and we'll talk about how to have these conversations with our patients. And so first, I wanted to start with a case study to give some context for our discussion. So we have an 89-year-old female with a past medical history of hypertension, hypothyroidism, osteoporosis, fibromyalgia, and hyperlipidemia. And as you see her out of the corner of your eye, you see that she uses a rollator to ambulate into the office. Her chief complaint is that she's had intermittent palpitations over the last several weeks, and these palpitations can last for several hours at a time. And during these episodes, she does have increased dyspnea with exertion. And these are her vital signs and her most notable recent lab work. And so you get an EKG, and this is what it shows. And you can see on here, it's irregular, no real discernible P waves. And so you diagnosed her with AFib. And so at this point, after explaining what AFib is and treatment options, you start to talk about anticoagulation. And so at this point, should you initiate anticoagulation for this particular patient? And what information do you use to guide your decision to start anticoagulation? And how do you weigh the risks and benefits? What concerns, if any, do you have about this patient starting anticoagulation? Are there any barriers, real or perceived from you, the provider, or are there any barriers on the part of the patient or their family? And we'll talk about how to navigate these questions today. And so there are several studies and surveys showing that a high bleeding risk is a major reason why anticoagulation is not prescribed. And a study in 2012 examined Medicare Part D patients with a history of AFib. And this study showed that patients who had been diagnosed with AFib within a year and who had at least a moderate to high stroke risk, 41.3% of them did not receive a warfarin or anticoagulation. And looking at Premier data, this included 1.6 million admissions from 812 hospitals across the country. And 46.2% of those patients received a oral anticoagulation at discharge. And those rates were consistent across a number of patient subgroups, including prior falls, previous strokes, and older age. And so thinking about, those were looking at warfarin specifically, and with the newer direct anticoagulants, there was a 2017 study using the Pinnacle registry between 2008 and 2014, looking at warfarin and DOAC use. And the prescription rates for oral anticoagulation increased mildly from 52.4% up to about 60% among eligible AFib patients. And so, the introduction of the direct oral anticoagulants in routine practice did show an improved overall rate of anticoagulation use, but at that point, significant gaps still remained. And, thinking about anticoagulation, there can be a mentality of, as providers, we first don't want to do any harm to our patients. And so, providers may feel more culpable from harm resulting from side effects from a treatment rather than adverse events from omitting a treatment. Like, for example, provider may feel more responsible for a major bleeding event after starting anticoagulation rather than an ischemic stroke for electing not to start anticoagulation, even when the potential benefits are shown to be greater than the risks. But these studies are a little bit older data, so what is the newer data showing? And so as part of the Get With the Guidelines registry in 2019, this just shows that warfarin use has decreased over time, and the use of the direct oral anticoagulants has increased pretty substantially. The direct oral anticoagulants are in orange and warfarin is in blue, and so you see that with the passage of time, it's definitely the percentage of warfarin use has decreased. And so continuing looking at that registry, there was analysis using the 115 centers enrolled in the Get With the Guidelines registry from 2013 to 2017. And this study looked at how to improve anticoagulation prescription. And some of the quality interventions included educational workshops and webinars like this one for hospital teams and providers, hospital toolkits for patient and provider education, and the availability of an internet-based decision support patient management tool. And at the start of this study, at admission, close to 60% of patients with an elevated risk of stroke, a CHA2DS2-VASc score of 2 or greater, and a previous diagnosis of AFib were on anticoagulation. So that was coming into the hospital. And so among eligible patients, the prescription rate at discharge was 93.5%, but when that was controlled to exclude patients with a strict contraindication for anticoagulation, the initial prescription at discharge was actually closer to about 80%. And then over the course of these quality improvements in this registry, the prescription at discharge improved to over 96%, which is pretty amazing. And so, it just shows the importance that these tools, these education programs do help to get the word out there about anticoagulation, about following the guidelines. And this graph over here, again, just shows the breakdown of which anticoagulants are used. And this is actually on the x-axis, we have the CHA2DS2-VASc score. And so, and each color represents a different oral anticoagulant. And interestingly, at the higher end of the CHA2DS2-VASc score, more warfarin is prescribed. Warfarin is the gray. And so at lower CHA2DS2-VASc scores, more of the newer direct oral anticoagulants, apixaban and rivaroxaban especially, are used. And so how do we decide who should be on anticoagulation? We've already mentioned the CHADS-VAS score, and these are the current guidelines, which received an update in 2019. And with a class 1 recommendation, it says that patients with AFib and a CHADS-VAS score of 2 or greater in men and 3 or greater in women, oral anticoagulation is recommended. And the options are listed: warfarin, dabigatran, rivaroxaban, apixaban, and edoxaban as options. Now, and the guidelines also do mention that the direct oral anticoagulants are preferred over warfarin in patients that don't have a mechanical heart valve. And so here's a breakdown of both the CHADS-2 score and the CHADS-2 VAS score and how we calculate that. And you can see that age and previous stroke down in the CHADS-VAS score both carry a weight of 2 points each. And so those are weighted more heavily. Those are more closely related with stroke risk. And in the third column, the adjusted stroke rate percent per year, you can see that with each additional point, the risk of stroke goes up. I like to use that percent adjusted stroke risk in my conversations with patients. So I can sit down and tell them your CHADS-VAS score, for example, is 5 because of your history of X, Y, and Z and your age. And that means you have a 6.7% chance per year of having a stroke due to AFib. And it really helps the patients kind of grab onto that and quantify it in their mind and wrap their head around what their stroke risk really is. Now, all of that is great, and we should be prescribing anticoagulation when it's needed, but it is still important for both patients and providers that we need to understand that the risk of having serious bleeding event on anticoagulation is real. It does really happen. And so this is a 2017 Danish study looking at real world outcomes for anticoagulation. And they defined major bleeding events as hospitalization for bleeding. And of patients, the overall percentage of all patients that they studied on anticoagulation, 4.5% of them did have a major bleeding event. And of those, 42% were GI bleeds. And this is a table, a breakdown from that study with, you can see gastrointestinal making up 42% of those major bleeds, followed by urinary next, and then intracranial bleeding. And so it's important to be upfront and honest with patients about these risks. It would not be appropriate to say, oh, I'm going to prescribe this medicine, you're going to do fine, you're going to be great, nothing's ever going to happen. Never say never, but just being upfront with patients about, it's possible to have a bleed and what signs and symptoms of bleeding to look for. And so now there are tools available that we can use to try to predict who is at the highest risk of bleeding. And so there's a few different models. The HAS-BLOOD score is probably the most widely used, and it has the best predictive ability for clinically relevant bleeding than some of the other models. And the other models are the Atria, Orbit, and Hemorrhages models. It is important to note that having a high HAS-BLOOD score does not mean that anticoagulation should be withheld from a patient if they meet that CHADS-VAS score criteria. The way that HAS-BLOOD can be used is that it means that this patient probably needs closer follow-up and that their risk factors for bleeding should be treated more aggressively. For example, if a patient has high blood pressure, is there ways that we can get their blood pressure down to not only treat their hypertension, but also lower their risk of bleeding? Talking to patients about their alcohol use, things like that. Now, despite the real bleeding risk, there is still a net benefit that's been shown for being on anticoagulation for almost all patients. And the benefits of anticoagulation in a study, in a Swedish study I'm going to talk about, the benefits were more pronounced with patients with a higher CHADS-VAS score and higher HAS-blood scores. And so this is the Swedish cohort study in 2012 looking at the net clinical benefit of warfarin. And on the large x-axis is the risk for embolic stroke using the CHADS-VAS score. And on the large y-axis is the risk for intracranial bleeding using the HAS-blood scores. And the little box inside, so the lower left-hand box is going to be the lowest bleeding risk and the lowest stroke risk. And the upper right-hand box is going to be the highest stroke risk and the highest bleeding risk. But you can see in each scenario, and the y-axis for the little boxes is proportion of surviving patients, and the small x-axes are years that patients were followed. And you can see in every scenario, patients on warfarin fared better, had less death from a composite score of all-cause mortality, intracranial bleeding, and embolic stroke. They did better in every scenario, including the highest bleeding risk patients. So it does show that warfarin is favored, and even other anticoagulations more so in these patients, even at high bleeding risks. And so, that's a lot of information to throw at patients when you're already telling them that they have AFib. So you're telling them that they have a heart condition. How do you sum up this data, these recommendations, all into the space of an office visit? And so from a study, Physicians' Fear of Anticoagulation in Non-Valvular AFib, this was put out in 2014, they list several points about how we can discuss anticoagulation with these patients. And so first, indicating the reason for initiating anticoagulation therapy and how it relates to clot formation. A very simple explanation of how AFib leads to a clot formation in the left atrial appendage or just in the left atrium goes a long way with compliance for patients. Reviewing the names of patients' medications, both trade and generic names, and explain why they're taking them. I'm sure this has never happened to any of you, that you've been seeing a patient for years and they come into the office and you ask them, are you taking your apixaban? And they give you this blank stare, and ask you, what's that one for? And so just it's an ongoing conversation that we have with patients, reviewing their medications and what they're for. Discuss how long the therapy is going to be needed. You're telling them that they have AFib, and many times the guidelines recommend indefinite anticoagulation. So being upfront that this medication, you're going to be on it probably indefinitely, or if it's short-term, post-cardioversion or post-AFib ablation, just describing how long it's going to be needed. And if the patient is taking warfarin, talking about the importance of regular monitoring, target values, and what an INR means. Again, if the patient's taking warfarin, explain the importance of dietary precautions, including the restrictions of alcohol and green leafy vegetables. Describing common signs and symptoms of bleeding and what to do if they occur. This is something that we really try to stress in our clinic when we initiate anticoagulation for our patients. We tell them what, to look for black tarry stools or frank blood in the stool, very dark reddish pink urine, or what to do if they have nosebleeds that they can't get to stop. So we try to educate them on the front end of all of these issues and let them know what to look for and to notify us or their primary care physician immediately so that they can be evaluated quickly. And on the flip side, describing common signs and symptoms of clotting complications and what to do if they occur. Do your patients know or what symptoms to look for a stroke? The think fast acronym, the facial droop, arm drift, slurred speech, time to call 911, talking to patients about looking for those stroke type symptoms. Outline precautions the patients to take to minimize the risk of trauma or bleeding. I don't think many of our patients coming into our clinics are participating in contact sports, but it's probably just a good reminder anyway. Now, it is important to discuss what to do if a patient should fall. Especially if they fall and hit their head. Thinking back to our case study at the beginning of the presentation, you see her using a walker to get into the clinic. And she may be a little unsteady on her feet. So you would definitely want to educate that patient about if she should fall and hit her head, she really does need to go to the emergency department to have a scan for intracranial bleeding. And then you also want to discuss potential drug interactions. I spend time educating patients about avoiding aspirin, Advil, Motrin. Trying to avoid NSAIDs is a big one. For women of childbearing age, explain the importance of contraception. You really don't want to be on these oral anticoagulants if you're pregnant. Explaining the importance of informing healthcare providers of the use of anticoagulant medication. I'm sure that the dentist pulling a bunch of teeth would like to know if a patient was on a blood thinner. And the reverse is also true, that tell the patients that they should notify you if they need to hold their blood thinner for any reason. Because sometimes, we've just done an AFib ablation and they can't safely hold their anticoagulation for 3 months post-ablation. And so sometimes the colonoscopy needs to wait if it's not urgent. Explain when and how to take anticoagulant medication and how to manage a missed dose. I find my one explaining this one with Xarelto or rivaroxaban pretty often, that it needs to be taken with a meal, and preferably the biggest meal of the day to increase its bioavailability. So making sure we're going over that with our patients. Discuss utility of carrying identification, medical alert bracelets or necklace. Many smart watches and smartphones have a place now on there where patients can put in their medical alert information right on their smartwatch. And then after doing all this, making sure that this is documented, that you did educate the patient on these risks and benefits and what to do if the situation should arise. Now, the last point is to validate the patient's concerns. And I think it's easy for providers to get into a routine where this conversation can become very rote. And we have this conversation several times a day, and we're going over all these things. But for the patient, this is the first time that they may be hearing this. And frankly, many patients get scared when you mention blood thinners. And many of them have had relatives who have been on warfarin for 20 years, and they've heard these horror stories. And so what do you do if a patient just refuses anticoagulation? They accuse you of putting them on rat poison, right? So if you're telling a patient that warfarin is the best option for them and they accuse you of putting them on rat poison, at that point, trying to re-educate, letting them see their stroke risk, trying to explain the net clinical benefit of warfarin in terms that they can understand. And if they don't want to do it, we respect their autonomy. And so just documenting in the medical record that we've discussed this with them, they understand their stroke risk, and they've opted to not be on anticoagulation at this time. One of the studies that I like to use if patients are very hesitant about starting anticoagulation, especially if they're worried about bleeding, this was a subgroup analysis from the Averroes trial looking at apixaban, Eliquis, versus aspirin in elderly patients. And so comparing the two, apixaban was better at preventing strokes in older patients who are 85 years or older. And down at the bottom, the rates of major hemorrhaging was similar in apixaban and aspirin in both younger and older individuals. And so if a provider or a patient is comfortable with the patient being on aspirin, the bleeding risk is fairly similar between apixaban and aspirin. And so, that's a good study to go to, that if they're comfortable being on aspirin, they should be comfortable also being on Eliquis. Now, for a small minority of patients, sometimes anticoagulation just isn't the right answer. So let's say you've had a patient and they had a GI bleed when they were on warfarin. And so, knowing the data from the Danish real world study, you know that Eliquis has a lower risk of GI bleeding. So once you get the clearance from GI, you switch them to apixaban and they have another GI bleed. And so they definitely are at high risk. Is there anything that we can do for these patients to still protect them from stroke without the increased risk of bleeding? And so at this point, you could consider a left atrial appendage occlusion device. I know this isn't a Watchman talk, but I did just want to mention this. The Watchman is the only device approved for use in the US. And here it is from the guidelines. It's a 2B indication that percutaneous left atrial appendage occlusion may be considered in patients with AFib at an increased risk of stroke who have contraindications to long-term anticoagulation. And kind of looking forward with Watchman, the evolution registry, and this specific study was looked at in 2017. So this is real world data looking at a large cohort of about 1,000 patients who were deemed that they could not take oral anticoagulation therapy. And so many of these patients actually did not use warfarin or any of the oral anticoagulations in transition after Watchman was put in, but they were either only on antiplatelet or they were on nothing at all after Watchman implant. And it didn't appear to affect the occurrence of stroke or other thrombotic events. So this is still an area that's developing. There's still more research and information that needs to come out. But for those patients who can't take a blood thinner, and may not even tolerate the recommended short course of anticoagulation when a Watchman is placed, this may be a place to go in the future, and it's going to be something that we'll need to watch. Now, just a couple other things, kind of in summary, wrapping up. For the majority of patients, the benefits of anticoagulation outweigh the risks. And a little education goes a long way with patients. The more that they understand the need for anticoagulation, the much more likely they are to be compliant to it. And making sure that while we're explaining the risks and benefits, that we still validate the patient's concerns. And we could think about left atrial appendage occlusion if a patient is not felt to be a good candidate for anticoagulation. And there's my references, and thank you all so much for having me.
Thank you so much for leading today's webinar. It's my pleasure now to introduce our moderator for Q&A, Jeannie Luciano, Senior Manager for AFib and Stroke. Jeannie?
Thanks, Liz, and thank you, Ricky, for your presentation and really for your obvious commitment to helping to optimize your patient education and patient management. I have some questions here. So, and we all live for the day that we don't have to bring COVID into the picture, but with the impact of COVID, the needing to wear masks, limiting support persons in the offices, and overall anxiety, have you had to modify your teaching and discussions? And have you seen patients via telehealth, and how is education different with that?
Yeah, great question. So when COVID first hit, way back in 2020 when this all started, we actually closed the AFib clinic for about 3 months. We would see patients in office only 1 day a week, and the rest of the time was all telehealth. And so, education was definitely a lot more difficult at that point. But we definitely utilized telehealth, and it was great. We actually used smart device technology like Apple Watches, Fitbits, KardioMobile to try to treat patients while we were all working remote. And as far as the education goes, when it was limited trying to bring family members into the office, we always allowed one support person, especially if the patient was demented or if they had trouble remembering or they were deaf, they couldn't hear. We allowed a support person. But if if they were sound mind and body coming into the clinic and it was just them coming in, we would have the patient call a family member, call a friend. We would even do FaceTime using the patient's phone there in the office. And so that family members could be part of the conversation too. And we found that that was really, really useful is, as soon as we walk into the room saying, okay, do you want to go ahead and get your family member on the phone? And patients were a lot more comfortable with that.
Great, thank you. So we all have patients who show up with like a plethora of information they pull from internet searches, and that may have false or misleading information, and of course they assume it's all true. Do you experience this, and any suggestions on how to handle this?
Yes, I mean, every day. And so, a patient will come in asking, is this vitamin or supplement going to cure my AFib? Or, um, I like the example earlier, you're trying to put me on this blood thinner, it's rat poison. That's what it's used for, which is, how warfarin was originally marketed before it was changed and found to be therapeutic for humans. It really was a rat poison. And so, they hear these things and see them. So that's probably the most common one. Um, Addressing these with a patient, I find that I have more faith in patients, and so I will actually pull out um, some of these studies and show them the data and try to explain it in the simplest terms that I can. That you don't have to get into all the biostatistician stuff of it, but just show them, look, here's the graph is going down or the graph is going up, and this is your stroke risk. Here's what the percent is per year. This is what peer-reviewed data has showed us. And that's not everything that they find online. And so I find that actually showing patients the data tends to have a pretty favorable outcome in patients' outlook. They feel like they're getting kind of a behind the scenes, peeking behind the curtain, seeing the data, the same data that we see.
Great, I love how you use research to support your care. So shared decision making may be unfamiliar, particularly to our elderly patients. Do you have any strategies for increasing engagement with them?
Yeah, that is hard because I think that there's definitely differences in generations. And so many times if I walk in there, I say, okay, well, here's our options. Doesn't not even necessarily with anticoagulation, but with starting a beta blocker for rate control, or say, well, here's our options. Here's our antiarrhythmic options. What do you want to do? And I get this look back like you're asking me what we should do. And a lot of them just say, just tell me and I'll do it. And we try to avoid that if we can, just telling our patients what to do. And that's a tough one. If the patient doesn't want to be engaged, it's pretty tough. I'll be honest about that. If they do show some interest, explaining the differences in therapies, saying we could do X therapy for this reason and Y therapy for this reason. And here's why, here's my reasoning as the provider. I'm telling you why I'm thinking about X therapy and Y therapy and why I would favor one over the other. And so if a patient is having trouble engaging, I will just kind of make a recommendation, say, here's what I would do if you were my family member. I would do this and think about it this way. And then remind them, but it's ultimately your decision, but this is the way that I would look at it if you were my family member.
Great. We have some challenges in getting patients to wear medical alert bracelets. Do you have a favorite system that you use or any suggestions on how to increase compliance with that?
I think that if they have, almost everybody has a smartphone and or some kind of smartwatch. Doesn't have to be the latest greatest, but most people wear at least a watch that can track their heart rate or something. Um, Smartphones do have a way that you can put on your medical information, and emergency personnel are trained to look for those kinds of information on smartphones. Some of the best technology users that I see in my clinic are my 85-year-olds, and they whip out their Apple phone their iPhone and they pull up their EKG strips from their Apple Watch and show it to me, and they're great at it. And I think so that's kind of the way that I'm leaning towards patients, rather than having, a medical alert bracelet that they wear or a necklace that they wear around their neck, is the smart technology.
Great. I have one more question here. So do
Mhm.
you have any specific strategies or resources that you can recommend for use in low literacy patients?
So, most of our material is read. We do have some social workers that work in a clinic right next to us that many times we will refer patients to. Um, that one's tough. We spend a lot more time educating in the office, and so if they have access to the internet, there are some good just YouTube videos that go over what AFib is. It's from several different um, medical education centers, whether it's a university or an body like the American Heart Association. There's a lot of videos that patients can watch if they have access to a computer and to internet, which a large portion of our patients do. We do have a homeless population come through our AFib clinic from time to time, and I'll be honest, engaging them can be very, very difficult. And we print out reading material. I don't know that it gets read, but most everybody, again, has some kind of access to the internet, whether it's through phone or a computer or a public access computer at a library. And so having a list of, here are the websites that you can type in and go to this website and watch a video, that'll help explain and reinforce what we talked about in the office today. And a lot of our materials also have pictures on them. We have a book that we give patients for new diagnoses of AFib, and it does have pictures in there, which is very helpful for explaining. But if they can't read it, it does make it more difficult. Yeah.
Great. Thank you so much. I appreciate your time today. I'm going to hand it back to Liz.
Great. Thank you, Jeannie, and thank you, Ricky, for your presentation today. And thank you all for participating in today's event. After today's webinar, you'll receive a follow-up email with a survey on the presentation. We'd appreciate it if you would complete that and provide your feedback. In that email, you'll also receive a link to view the recording from today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us. Have a great day. This concludes today's presentation.